So as we see, the season of war is probably all over the world, but our refractive surgery is not far from that. We have got a lot of options here with war and everything. So the war is of war of flaps. That means the different techniques we are using for refractive surgery. Our first speaker is Dr. Monica Jethani. She is very renowned cataract and LASIK surgeon from Vadodara. She is the director of the Eye Clinic Vadodara LASIK Center at Vasna Berry Road in Vadodara. She is a gold medalist, a prestigious organization, the DNB. She got Best Paper Award in Gujarat Ophthalmical Society and Best Video Award in Maharashtra Ophthalmical Society. She has also conducted various state and national level conferences. She has 6 publications in the Index Journal. She is a multi-talented woman with dignified personality. She has a lot of social and other achievements. She is practically a role model of the Year Award she won for WOS and Women Ophthalmologists Worldwide. She got first prize in the fashion show in Women Ophthalmical Society. She got gold medal for the district chairperson of the site first, Bharat Gaurav Puruskar from KTK Outstanding Achiever and Educational Foundation, Excellent Award from Lions Club and International Eye, and many more. So she's already conducting a lot of ICs and other instruction courses in AIOC and other conferences. Dr. Monica Jethani will be speaking on microkeratome LASIK is still the best. Second speaker we has Dr. Hemlata Gupta. She is senior consultant cataract and refractive surgeon at the Center for Sight Group of Hospitals. She had done advanced LASIK training from Baroda, presented over 500 papers in national and international conferences, published 40 papers including chapters in textbooks. She won gold medal by IRSI and also Future Leader Award by Center for Sight. She is going to speak on femtosecond, a safer LASIK. Dr. Hemlata Gupta will be speaking on that. The next speaker is Dr. Chandrasekharan Wavekar. He is an ophthalmologist, philanthropist, innovator, and mentor. He is pioneer in eye care innovation and got Asia's first femtosecond laser cataract surgery developed, also part of the development in the Wavekar Subhash toric tools. He is the founder of NABH accredited Wavekar Eye Institute. His philanthropy with impact, he has done over 150,000 free eye checkups and 7,500 free cataract surgery through 5,500 plus camps. Academic leadership, established Wavekar College of Optometry, DNB Ophthalmology Program, and Fellowship in Cataract and Refractive Surgery. His aim is empowering the next generation with programs like Thane Vision 2030 and Drishti. Dr. Wavekar has contributed immensely to the inspiring young minds and helping them understand the path to excellence across various fields. He is going to speak on the latest innovation, that is Wavelight Plus with Innovis. Then we have Dr. Anand Parsarthi. He is the Chief Surgeon of the Center for Vision and Eye Surgery at Chennai. He did fellowship in refractive surgery, cataract and cornea, all 3 at the University of Erlangen under Professor Klaus Soren in Germany, Singapore National Eye Center, and Dr. Nagarao at L.V. Prasad Eye Institute, Hyderabad. He is the winner of Best Paper Award at the American Academy of Ophthalmology in 2007. He was also awarded C.P. Gupta Award at the Tamil Nadu Ophthalmic Association. He got E.T. Album TNOA Postgraduate Award in 2001. He has his credit to publish more than 35 peer-reviewed articles. He is a regular invited faculty at SCARAS, ISCARAS, APO, WOC, SOC, AIUS, DOS, BOA. In fact, today he's also having a lot of ICs here. He's going to speak Smile All the Way. It's me, nothing much, but I'm at Dehradun. I've been past president of IIRSI and UKSOS, has been member managing committee of IOS, published more than 30 papers, introduced 2 minutes to win my tip this year at national and international conferences, presented over 800 papers, keynote addresses, and ICs at national and international conferences, won Best Paper National Award in DOS, awarded IAS Gold Medal at Chennai, awarded IGO Honor Award for Peer Review, Dr. BP Kashyap Oration Award by Jharkhand Ophthalmical Society in 2023, awarded ISCRS Excellence Award for Outstanding Contribution to Refractive Surgery, and FACO Examiner 2023 and 24, and recently won Best Paper Award at AIOC Midterm Conference. I'll be speaking on how advanced is the advanced surface ablation. So, without wasting time, I would like to request Dr. Monica to come and start his presentation.
So thank you so much, Vinod sir, for this wonderful opportunity. This talk is very close to my heart, and so I stand here in front of you all talking about microkeratome LASIK in today's scenario where we discuss silk, elita, contura. So why are we still discussing about microkeratome LASIK? So we want to know that, is it going to stay, or we are going to say tata bye-bye to microkeratome LASIK in coming 5 to 6 years. So there are a variety of microkeratomes available in the market, and the whole innovations have already been done in the field of microkeratome. Since years we have not seen any development going on in terms of microkeratome. So initially 10 years back we used to talk about, 10 to 15 years back, we used to talk about different types of microkeratomes like manual versus automated, pivot versus sliding type, disposable versus reusable, mechanical versus water jet or laser, rotatory versus linear. But now we know which one are the best and which one do we need to use. So what used to happen with the rotatory microkeratomes was it used to display a meniscus configuration which used to be thick at the periphery and thin in the center. Whereas now with the linear microkeratomes, it is a planar flap which we get. So this is a busy slide showing different kinds of microkeratomes and what they offer. What is the flap thickness, how much time do they take to make the flap. So this is a very famous saying that old is gold, and I still believe that microkeratome LASIK is here to stay. How? We'll see in the coming slides. So we all stay in India where we have to consider socio-economic status. So refractive surgery is not only for the rich who can afford SMILE or femto or phakic lenses, but it is also for the middle class and the lower middle class people who have glasses and who want to get rid of those glasses. I have operated innumerable patients who are farmers' kids who want to get into army, police. You know, they get selected and the only hindrance in their medical examination is the glasses. So for those patients at least microkeratome LASIK is going to stay. This is one of the most important slides which we all should remember, and if we take this home, I don't think we'll land up into any of the complications. So now with microkeratome we have disposable, not only disposable blades but disposable heads also, and there's a company recommendation not to reuse the blade. What happens with femto and SMILE is that they are bar-coded, so we don't, as doctors, we don't have an option of reusing them. But with blades, to save the cost, we try to reuse it, and that is how we tend to land up into complications. So initially when the femto was launched, the good part was that it could make a 90 micron flap, it could make a thinner and a nasal flap. But all these are possible with SBK and ML7. So cons that were thought at present for the microkeratomes are buttonholes. I don't think in my career of 15 years I have come across a buttonhole, free or incomplete flap, or epithelial defects due to mechanical nature of the blade. But the reality check is the incidence of the free flap is less than 0.1% in experienced hands. So basically what we need to take into consideration at this point of time is the vacuum settings. Vacuum is the most important part. If you have taken care of it properly, I don't think you'll land up into complications. Only if you are complacent about your vacuum settings, you are bound to land up into flap complications. So yes, it was thought that it may create thicker and less uniform flaps, which may limit the amount of tissue available for laser ablation and increase the risk of ectasia. But it has been found that femto and LASIK have comparable rates of ectasia, and post-op wow effect is seen in both. In fact, I would say it's more with microkeratome LASIK compared to femto or smile on day 1, which subsequently becomes the same. So limitations of smile still are hyperopia. I would not say not treatable. Now there are doctors who are in the experimental stage of that. And one of the most important points which I would like to highlight is the flat ad. So in Alzheimer's, we are trying to reduce the tissue use. And in smile, we have to add 15 to 30 microns of tissue, right, to remove the lenticule. And it is not only for low diopters. In all the diopters, you have to have 15 to 30. 15 is minimum, and you can have up to 30. So that accounts to 1 to 2 diopter of correction. And we all say that it's a all laser correction, but we all must agree that it is not an all laser correction, and in fact there is more manual separation needed in smile compared to a microkeratome LASIK. Though I just had hands-on experience with silk, and I would agree to that the name signifies itself, and the dissection is much easier compared to smile. So yes, we are progressing towards that, and in coming future, smile or lenticule assisted surgeries may be the future, but what we have to understand is the cost. So opaque bubble layer is now the thing of past. It is a steep learning curve, but not that much. So LASIK has the pros. It is very predictable, quick recovery, high diopters can be treated, hyperopia can be corrected, thinner flaps are possible. The cons are two-step, flap complications may occur, and folds and stria may occur. So take home message is old is gold. It is cost effective. Reuse of the blade should be avoided. Manual separation is needed in femto and smile. No buttonhole with near microkeratomes. 90 micron flap is possible. Nasal flap is possible, and it's value for money. So what we have to understand in a refractive surgery practice is that pre-operative workup is the key to your success, and we have to understand that the show must go on. From microkeratome we'll move to femto, to smile, to robotic surgeries. We have to understand that it is you as a surgeon who is important and not the machine. So yes, we should be progressive and we should be moving towards the future, but we have to buy the machine when our heart says that yes, it is good for our patient, rather than, because of the competition in the market. Thank you so much.
Thank you so much, Dr. Monica. It's a wonderful presentation. I think the technology is improving in every aspect. It's not the new technology, but the older technology like microkeratome, they have come through the ages. Now we can get a planar flap, we can get an oval flap, we have nasal temporal flap also. So these things have improved a lot. Dr. Monica, my question is, we see the minimum pain or the earliest recovery with the SBK system.
Yes, sir.
Compared to femtos or smile or advanced surface ablation.
Yes.
What may be the reason? Why
So
they quit?
because it's a very smooth cut, and
That occurs in femto also.
That occurs in femto, but because the laser is used more,
Yes.
and that is why, because I have done femtos, and initially now the protocols have evolved quite a lot, so we do not need that much steroid. But earlier femto machines, we needed more steroid compared to microkeratome, and there was a lot of opaque bubble layer formation. So there was more laser which was used, and there is a tissue bridge in between which needs to be separated manually. So there is a very smooth cut which with microkeratome which helps in smoother recovery and healing.
Yeah, it's important. It's a very smooth cut, and I think beside this, there's no use of energy. What the femto energy you're using, examer energy is
Absolutely.
very low, so that doesn't cause any problem. But once you are not using a femto energy takes time to recover.
Absolutely.
So our patients, like say SBK, they feel irritation itching for 2 to 3 hours max. For a femto patient, I think they may feel like 5 to 6 hours.
Sir, the most important take-home message which we can take is not to reuse the blade.
Yes.
If we do not reuse the blade, the patients are very, very comfortable.
Yes, that's an important message or take-home message. Please try not to use blade. You can maximum use for one patient, not more than that.
Absolutely.
It's recommended to use on one eye only, but max you can do is maximum 2 eyes. So you'll get a better results, less pain, less comfortable, less distortion. Everything will be perfect at that time. Thank you so much.
Thank you. Thank you, sir.
And our next speaker is Dr. Hemlata. I have already given the introduction of all the speakers. Dr. Hemlata, she is going to speak on femtosecond, the safe LASIK. She is a consultant at Center for Sight. Now it has come in the form of a smile. We used to do PRK, it has come in the form of advanced surface ablation. So thing comes back in a better way. The idea hardly dies. Dr. Hemlata, please.
Very good afternoon to all of you. So I'll be talking about the femtosecond LASIK. So femto laser is a ND class laser that emits ultra short pulses of light, and these pulses are like high energy pulses, and for a very brief duration it cuts the tissue very precisely, and there's no like collateral damage. So if you compare the geometry of the flaps created with the femto laser versus flaps created with the microkeratome, the flaps are meniscus shaped in microkeratome, while with the femto laser they are thinner and more planar. So this is how this is a small video showing the femto laser. So we just apply the suction ring, and once the cornea is applanated to sufficient extent, then the laser is passed. So there is a pocket, there is a posterior plane, and then side cut. This is the OBL. Sometimes it's very dense, sometimes it's light, but usually it doesn't interfere with the separation. You can see that despite this OBL, the separation is not any problem. So it's a very smooth separation. So sometimes this OBL can interfere with the eye tracking system, but most of the times if you wait for 1 or 2 minutes, the OBL absorbs and there's no interference. You just fire the laser and put the flap back. I'll show what are the advantages of femtolasic over microkeratome. So once the laser is complete, we just simply oppose the flap. So this was intralace, and this is a very short video on how the flap is created on VisuMax. So the different companies are playing with different parameters, and with VisuMax we use VisuMax in our center to create the flaps, and it's a very quick machine, and it's very easy. The docking is very easy with the VisuMax. There is hardly any OBL and the separation is very easy. So precision of flap creation is plus minus 5 microns with femto laser. So you can play with the diameter, the thickness of the flap, the hinge position also. You can make it nasal, temporal, superior-nasal, superior-temporal. So you can alter the hinge position. You can play with the side cut parameters. So femto allows us to change the geometry of the flap also. So this is just to show that how the two machines are different, but most of the steps are almost like similar. So coming on to the geometry of the flap, it's much uniform and it's thinner than the microkeratome flap. Now the main advantage over the microkeratome is that in microkeratome most of the times the flap, the side cut is around 70 degrees. So with femto laser it's inverted side cut. We can increase the angle of the side cut to 90 degree to 115 degrees. That makes it inverted side cut. What is the advantage of the inverted side cut? There is lesser epithelial ingrowth, better biomechanical stability, lesser incidence of dry eye since lesser nerves are cut. So this is how the OBL forms. It can form early, dense, or it can form in the late stage. Generally, it doesn't interfere with the eye tracker system, but sometimes, most of the times, it's like it disappears after lifting. Sometimes it interferes with the eye tracker or pupil recognition. Sometimes there are difficulties in lifting or intraoperative pachymetry measurements, and very rarely it may reach the anterior chamber or escape into the subepithelial layers causing vertical gas breakthrough. So this is one of the cases we had in the beginning, in the earlier stages. This is the only case I have seen of vertical gas breakthrough. This was with intralace. So you can see that now a bubble will appear. Yes, this is the bubble. So there the gas came out from the epithelium and Bowman's membrane. So we proceeded with the dissection. So it's thinking that it's in the far periphery. So most of the time if your ablation zone area is fine, you can still proceed with the ablation. But in this particular case, you can see that there is a flap tear. So there was almost like 5.5 millimeter ablation zone, but the flap tear was like quite large in the periphery. So see, so this is the area which is where the flap has got damaged. So in this particular case, we didn't do any laser ablation, put the flap back, waited for 3 to 4 months and then proceeded with the surface ablation procedure. So this is the only case in the last 18 years that I have seen. Then chances of epithelial ingrowth are very, very less with femto laser. They're more with the retreatments rather than primary surgery. So I have few cases where we remove the epithelial ingrowth. So this is the area which you can see there's a dense epithelial ingrowth present in the visual axis. So we just need to identify the plane by dipping the instrument perpendicularly, and then we separate the flap. Relifting the flap is not an issue, but in the area of epithelial ingrowth, if there is stromal melting, it can further damage the flap. So one has to be very, very slow and gentle in separating that area. So you can see that even the outline is irregular. So you just slowly and slowly separate that area. You can use the Merosil sponge or the dry sponge. Since it's there in the pupillary area, so we don't want to damage. You can see that most of the times the whole epithelial nest, it comes out very easily. So you just need to carefully remove all the epithelial nest to prevent any recurrence of the epithelial ingrowth. In this particular case, you can see that the flap margins are also very irregular. So there are chances that recurrence can be there. So in such cases, we prefer that after cleaning the epithelial ingrowth and removing all the nest from the stroma as well as from the underneath the flap, we dry the flap and then we apply the fibrin glue. So fibrin glue helps in the epithelialization in the earlier days, and then it prevents the recurrence of the epithelial ingrowth. So after washing all the epithelial nest, You can see there's no underlying stromal melting. Stroma looks healthy. We put the flap back and then apply fibrin glue after properly drying the flap in all the areas underneath the flap as well as the stroma. So not all the cases fibrin glue is required, but some of the cases where the flap margin is irregular, it's always better to apply it. So after the application of the fibrin glue, whatever excess glue is there, that is removed. And we place the bandage contact lens. That completes the surgery. This is the post-op picture. Even after 10 years of the epithelial ingrowth removal, patient is doing well. So this is a case of flap stria. This is again after the femtosecond laser. Here the flap thickness was 90 microns. The patient came to us with trauma. He rubbed his eyes, and you can see there are like extensive macrostria. So in this case, we need to relift the flap, remove the stria, and it's always better to visualize the stria under retroillumination. And slowly with taking like we hydrate the flap and then take 2 Merocel sponge and iron it out. So these are like fixed folds. After removing the epithelium, it takes a lot of time. It takes around 8 to 10 minutes for these to unfold. So sometimes in these kind of extensive stria on table, you don't see that the cornea has unfilled, all the folds are removed. But on day 1, usually the cornea is clear. There are no stria. This is a very, very interesting case in which the patient came to us after you can see this is the flap and this is the flap. Bilateral displacement of the flap after 1 day. So the patient said that when I reached home after few hours of surgery, I stopped seeing, but the patient didn't report to us. The patient came back to us after a day. So we took the patient in the OT, and within say 16, maybe 17 hours, 16, 17 hours, there were fixed folds. I was not able to reposit it back, so we had to remove the epithelium to remove those fixed folds. So this patient, bilateral displacement was there because it was hyperopic ablation. It was high hyperopia. So in high hyperopia, generally most of the ablation occurs in the periphery that can destabilize the flap. So it's almost similar to the stria removal. It's just that in this patient, we had to do the procedure in both the eyes. Since it's just the day 1, so we just had to remove the epithelium, hydrate the flap, remove the stria, and no fibrin glue was required in this patient. I'll just skip rest of the parts because it's almost the same. So in as compared to microctome, the specific indications are normal steep cornea. There's no risk of buttonhole in steep corneas. In flatter corneas, there's no risk of free cap. Femtolaser is much safer in flat corneas or irregular corneas or highly steep corneas. So the advantages are high precision of the flap creation, very reduced risk of complications, lesser higher order abrasions, reduced dryness. The main advantage is customization. We can play with the flap thickness, hinge, diameter, or the side cut variations are possible, and it gives better outcomes in hyperopia and irregular corneas. Thank you so much for your kind attention.
Thank you so much, Dr. Himata. You've shown a wonderful thing, and in the safe LASIK, you have shown a lot of complication also.
Yeah.
So nobody should get disheartened by this thing. Complications are practically very, very rare, but that can occur with any procedure. So the best thing is you have to be prepared for them. You should know whatever the procedure you're going to start. So, Dr. Hemant.
So we can use alcohol also, so that also removes you can reduce the chances of buttonholing and damaging the flap. But usually we remove with the scraper only. The hockey stick, it removes. I have shown in all the videos.
The second thing is most of the strice starts from the hinge. So if you are doing the central
You
part
just
only, it will not take care of the hinges. So you have to go till the hinge. You have to remove from that area, because it starts from there and then spreads like this. So unless you are going to treat the hinge area, it's not going to be removed anyway. You can use a forceps. You can just gently clean it. It easily comes out.
You just get this peeled off, as I shown.
Yeah. So it easily comes out. If you want to use a laser, you can use it. Only thing you have to decenter it, because again you don't want the central part only. So no, not necessary. Only thing, the area of the hinge area, that has to be taken, plus some of the central area. You can, no, not at all. Even little the flap area, that will go. It starts from, it's like just a knot starting from that place. So if you are managing the hinge area, that will take care of everything. So that's important. Don't neglect that part. Yeah, please.
Basically, you have to dry the cornea and move the hockey stick knife away from the hinge. That is the way. Once you get a small opening, then it becomes very easy. Second thing is that whenever there is a epithelial ingrowth, but without any track, then we can try YAG laser.
I have done YAG laser, it's excellent, but for that it has to be in the periphery. We cannot do YAG laser in the central area, visual axis area. But it's excellent in the early cases, and we have got very good results with the YAG laser.
Correct. And what is the last point? Yeah, bilateral dismembrane. Had you given bandage contact lenses?
Yes, both the eyes. Yeah.
So femtolesic, the biggest advantage with femtolesic is that if anything goes wrong while you're making flap, your epithelium is still intact, your flap is still intact, you can redo it in most of the cases. You can redo it. Start from you just cancel it and start from that part again. You can do in the same procedure. But if you are not able to do it, you can do advanced surface ablation. You can leave the patient because you have not make any change. Unlike microtom, if you got a cut flap or something, the patient is feeling helpless and you have to wait again for it. In this, if anything goes wrong, and even if you have to postpone the procedure, you can do later on also. So there is no change in the refractive problem. The patient is very, very safe. Second point she mentioned is the customization. You can play with the size of the flap, thickness of the flap. That means if you are making a 90 flap, it will be 90 micron everywhere. It's a totally planar flap. So there will be no optical aberrations which can occur with other things. Third, if you want to keep the hinge on the temporal side, if you want to keep the hinge on superior side, you can just play it there. Fourth, you can get an oval flap in this very easily. So it gives you choice to make a oval flap. Suppose your axis is at 180 degree. So you want to have more flap on that side, so you can just increase the size from 9 to 9.15 or like this. So you get a little oval flap that's take care of your cylindrical number also very well. And for hyperopia, since the this hinge is not coming in the optical zone. If you see with the microchrome, it is just like a D shape. Because the hinge is making a flat portion there. So it's taking some part of the optical zone also. So that makes little difficult if you're doing hyperopia in those cases, you may damage the hinge also. But in this case, the hinge is outside the optical zone. So you can very well do hyperopic correction that's going to stay there. So these are some of the benefits that's over microchrome. Otherwise, both the things give very good results.
Very good points, yeah.
Sir, excuse me. Sir, how much energy is appropriate YAG for this fibrous ingrowth?
I do not know this thing, but it is like, I think 1.6 or 1. Very low.
Very low.
Even lesser than that, no? Yeah.
Yeah, basically it has to be optimized. I think your technician can optimize that thing. The engineers they optimize the energy for you. Once you get a smooth flap or smooth lift, then it's okay. That should be there. So they optimize the things.
Sir, I'm asking about ND YAG.
Yeah, I'm sorry.
Okay.
And
Low end.
Only central part has not to be touched down.
And Dr. Hemlata, what's your flap thickness? Usually you're keeping it in your cases, 100 microns. I'm keeping 90 microns, but in AIMS, some of the doctors, they are keeping 80 microns also. Dr. Sudarshan Hooker, and they are doing regularly 80 microns. So my machine gives minimum 90 microns. I've kept it to 90 microns for routinely. So you can play with that thing also.
Suppose the refractive error is less and your PTA is something like 25.
Yeah.
Will you increase the flap thickness?
No, I don't change because the 90, I'm very happy with that one. I'm not finding any problem or any complications. So why one or to preserve the tissue, whatever we can do.
What about you, doctor? Standard. 90, yes. No. See, there are three situations. Number one, partly the thread is coming out of the hinge or the side cut. We have to tackle that. We have to next day take the patient to the OT and remove it. Second thing is that if it is in the pupil area, again we have to be aggressive and remove it. But if there is a small thread which is outside the pupil area but not in the side cut, just wait for 6 months, 1 year, it will disappear.
If there is no reaction and the vision is good, you can leave it.
Correct.
If, yeah, as sir is saying, you can leave it there, it's not going to cause any problem. But if it's causing some reaction, you see something spreading out from there, then you have to remove it.
Very good. Yeah.
He is well-renowned eye surgeon from Mumbai, and he's having Wavekar Eye Institute there, which is the first NABH got in 2010, long before anybody thought of it. And he's a known ophthalmologist, philanthropist, innovator, and mentor, and a good friend of mine. So I've already given the introduction, yourself first to the audience.
Yeah, thank you very much for the kind words. So with Dr. my talk was on Contura, but because I am doing Wavelight Plus with Dr. Arora's consent, I added Wavelight Plus also. So we know that there was a problem long time back when patient used to be not happy with the night vision, okay, and then came the wavefront guided LASIK, but it tackled only the pre-existing HOA. The HOA which are induced by LASIK procedure. Okay, there were two things. Number one is improvement in the laser platform. Second thing is that improvement in the flap, as we discussed just now. And the third point is, ablation, improvement in the ablation. And from there came topo-guided LASIK. Topo-guided LASIK previously we used as a reparative process, increasing optical zone, decentered ablation, correcting that. But the refractive effect of that was not known. You're ablating 10 microns here, 6 microns here, and therefore you should live with cylinder, spear, like that. Contura was the first time we found a robust mathematical calculation for the refractive effect of topo-guided treatment. And that is why they started doing it on virgin eyes, okay? And USFDA, that's why you treat not only pre-existing, but also the HOA. But pre-existing, you are treating now not entire eye, you are treating only the corneal HOA, and also tackling the HOA induced by LASIK. So, when USFDA went into trial, it wanted data for LASIK, topo-guided LASIK in primary eyes. And that's where they found out C4 to C12 compensation. So C4 is the refractive error and spherical, and C12 is the spherical aberration. Similarly, there is a correlation between astigmatism and coma. They are brothers and sisters. Okay, so we found out a calculation for that, and then we started getting plano. Okay, so what are the results of USFDA trial? Higher percentage of the patients with higher uncorrected visual acuity, with better quality of vision, no or less photic phenomena, and they won't mind referring the patient for another procedure, their friends for that procedure. So how do you do Contura? So Contura is a name given to topo-guided LASIK for primary, as a primary LASIK. So you have a topo vario machine on which the readings are taken, and then you have the examiner laser EX500. So you take the, and there in between there is a workstation. So now you take the readings over there, okay, and there is a very good comparisons chart when you can compare various maps, and you have to especially see the central 3 millimeter pupil. In that area, the variation between two maps should not be 0.75 or more. But what we are strict, so we don't go beyond 0.5. And this is the nomogram suggested by Alcon. So we started with this. Somehow we are not happy with this because it says that you reduce the cylinder by half. Why by half? Why not 130? 30%. Why not 60%? But as the time when we realized that this guidelines make sense, and we stuck to that till the end. Okay, so this is an example. These are the maps. You just look that you are just looking at the raw data, sagittal and dynamic, and the Q value has to be negative. And any map which is abnormal, you delete. Okay, so that the last line, that MAD has to be within subclinical level. Then on the workstation, you write down, pachymetry and pupil diameter, and here comes the stage. Over here, what I've done is that I've entered refraction as 0. So because of that, whatever is left is only HOA, higher order aberrations. Now, there is a difference of 10 microns, in the periphery over here, and 4 microns in the center. So 6 micron difference. That will turn out to be approximately 0.4 to 0.5 of refractive error. And we need to compensate that. So there are two methods of compensation, either this way, and second is that you click on this Zernike, and this is what you get. C4 and C12 you have to balance. And it's a very simple formula how to do it. Previously we used to break our head quite a lot on calculation, but as the time went, it became very simple. Benefits, it's an excellent procedure, better quality of vision, small learning curve, but gratifying not only for the surgeon but the patients, and patients' own Q value is preserved, and the treatment is centered on the corneal apex. The discussion of Contura cannot be complete without Forcidis. Forcidis is an analytical engine to understand what is exactly happening to the cornea with our treatment. This is not approved by Alcon. It is given by Dr. Mark Lebanov, but it's a fantastic machine, and most of the people who are using, doing Contura are using this. So what it does, it gives numerical value to the bumps. We call them talus. Okay, so numerical value in the sense either microns or diopters, and you understand the astigmatism is arising from 4 sources. It titrates all of them. Okay, and this is the entries that you get. You can see that if you do wavefront optimized treatment, this is what you treat, and contourated, this is what you treat, and just enter this, and the result will be bang on target. Another use of Contura came when we started topo-guided PRK. When we did only long time back, we did only C3R. Patient was stranded. Patient vision remained at 618, even though keratoconus stabilized. But what about visual rehabilitation? So this was an excellent tool, and believe me, treat only HOA. If the corneal thickness is sufficient, patient improves to 6/6 partial, 6/6, 6/9. So now we go to the second thing, that is the Wavelight Plus. In Contura, you are measuring only the corneal aberrations. Whereas in Wavelight Plus, you are doing aberrometry plus tomography plus A-scan. Okay, and a model of the eye is created that is called as a digital eye twin, and the treatment is given. Now this is a busy screen. This is on the site map. Everything is important. The spherical equivalent, the cylinder, and the stick tells us whether the reading is valid, and all this. Now you see that when I click on this stick, this is what I will get. So validate the data, check. Same thing for the keratometry, topography, and for the axial line. Now then we go to the workstation, select the optical zone, choose whichever maps you don't want, just like Contura, and go ahead with the treatment. And this is the final place where there is some nomogram has to be applied, some cylinder check has to be done, and go ahead with the treatment. When you click, you will understand the HOA, but this is total HOA. That in Contura it was corneal HOA. Okay, and then you go ahead with the treatment, and cyclotorsion registration is very, very important. Without that, don't go ahead with the treatment. Now results at Vavikara Institute, you can see that as the vision, preoperative vision, whenever it was less, patient has 2-line or 1-line improvement. But when the patient's vision was 6/4 preoperatively, there is one patient who lost line. And the same data we have got from US FDA trial also, exactly same. So what it means is that this is not because of the wavelet, it is because of the quality of LASIK. So doing extraordinary quality of LASIK is very important, and we have to be really master at doing LASIK if you want to touch a technology as sophisticated as this. Thank you.
Excellent. I think this new modality is going to help us a lot. Dr. Vavika, do you take the refraction by this machine only, or you take the manifest one?
No, sir, we cannot trust the refraction.
You are not taking the refraction of this machine?
No, we have to do refraction by, subjective refraction, dilated AR, dilated retinoscopy, meaning cycloplegic retinoscopy, and then wavefront refraction, and from that we come to final refraction.
And what do you see if you say that there is a difference in the axis?
Yeah, if there is the axis difference of more than 20 degrees, then you don't go ahead with wavelight plus. If the cylinder there is lot of difference, then you conclude that there is intralenticular astigmatism, and we don't know how the patient will behave postoperatively. So the data will not be taken care of. We will not go ahead with wavelight. So initially my rejection rate was as high as 70%. But now, understanding the situation, the rejection rate has gradually come to 20%. So 20% of the patients who want Wavelight Plus, I still have to tell them, sorry, I can't do it.
But the company people claims that you have to take the whatever you get in the machine. Maybe some marketing.
I am not employee of that company. I will do what I feel right.
No, one should be very sure.
Correct.
And my second question is, you are treating wavefront aberration also, that you're treating on the cornea. So is that interpreted? How is done that way?
Correct.
Because you're correcting the cornea, not the aberration inside.
Correct. See, it's a very, very good question. I had gone to Narendra for a conference where patient had a corneal cylinder of -5 at 90, and patient's refraction was -10 at 180. Okay, they had actually shown that case. So just understand the amount of internal astigmatism patient had. And any treatment other than wavefront optimized LASIK would have been a disaster. So, it is, again we come to do the same thing. We cannot do things blindly, and there is significant learning curve in everything.
Right. So I think the message is clear. If you're getting too much variation, play safe, then do wavefront optimized. If you're getting almost equal to that one, I think this gives a fantastic results. Thank you, Dr. Vavika.
Thank you.
Dr. Anand Parthi is, I think he's having a course elsewhere, so he'll be just joining it. So I'll jump over and do myself first. I think it doesn't matter. So we are going to a newer thing that was very, very old, probably the first one, the PRK, which has come into new avatar, and we don't call it PRK anymore because the name has got a bad name. So we call it advanced surface ablation. And in fact, even a more modified name that's called epicontura. So it started the refractive surgery with RK, AK, PRK, LASIK, interlace, epilasic, SMILE, advanced surface ablation, then Wavelight Plus, just we talk, and the things are still moving. So there's a lot of progression that's going to happen in every field, and we have to be ready. And luckily in the surgical armamentarium of refractive surgeon, now we have got a lot of options. So one shoe does not fit everyone. So we have to tailor-made the choice. Whatever is good for a patient may not be good for other. So initially it was PRK, which was much better than RK. It was more accurate. Myopia, hyperopia, and astigmatism were treatable. The results were stable. The problem was we were using a broad beam laser. That caused more pain, delayed hearing, and scarring in these cases. Then came the LASIK. It was a rapid recovery. There was a wow factor. Patient was very happy on the next day. Decreased risk of scarring. There is no pain. But some flap-related complications still persisted, like flap stripe, button holding, partial flap, debris, epithelial growth, DLK, late trauma, ectasia. Of course, these were very rare and still are very rare, but this can happen in these cases. Then came the FEM2, which was comparatively flap-related complications gone down, but it has its own complication rates also. So ectasia can occur even after FEM2 LASIK. So it was there. Late trauma, that's Dr. Hemrat has shown, it can be displaced. Then came the SMILE. SMILE has a very wonderful thing, but at present there's a lot of limitations. Hyperopia, people are trying it. Probably in coming years we can treat it, but at present it's not available. Customized treatment, if you want to do topo-guided treatment, like Dr. Wabekar has shown, it's not possible. If the cornea is irregular, is it traumatized or scarring, I think it's not going to help you. Difficult in low power correction. If you want to correct low power, you have to take a table of tissue with that piece. That takes the purpose of doing a safer surgery again, because you're ablating more tissue. Then if you have to treat bitoric or mixed astigmatism, it's very difficult because cyclotorsion compensation is not there. So people have tried it manual. With the newer machines we are getting it, but it's not that perfect. And for a FEM2 LASIK, if there is a decentration, it's not going to affect the refractive outcome. Slight decentration doesn't matter. But if a SMILE you get a decentration, high comma aberration, I think it's very, very common. And in many cases it persists even for 6 months, in routine cases also. Then came the advanced surface ablation. There are some indications which are over LASIK or SMILE. Of course, it's not in mainstream now. So if you got irregular astigmatism, FFKC, if the cornea is thin, if there's night vision concern, glare from large pupillar flap, if there are anterior stump opacities, you can correct them also with this. Contracted sports or hazardous duties where chances of getting injury are more. If there is a prior RK or AK, and if you want to do customized treatment, and the patients who earlier has gone to RD surgery, filtering blab is there, deep sight eyes are there with prominent orbital roof, it's difficult to put your PI or your ring in those cases. That become very difficult. And as just Dr. Webker has told, you can combine with C3R. So the contraindication, just like any LASIK surgery, herpes zoster, active dry eye, if there's a glaucoma, if there's irregular astigmatism like ectasia, keratoconus, PMD, keratoglobus, you will not do it. Uveitis, if there are lenticular changes, it may progress. And if there is a progressive retinal pathology like myopic degeneration, diabetic retinopathy, RP or RD, one should avoid in these cases. Of course, I've done a few cases of NRP, it doesn't matter much, but ultimately the vision gradually goes down. So you have to counsel him well. Then systemic contraindication like diabetes mellitus, pregnancy, lactation, rheumatoid arthritis, SLE, these are common to all LASIK procedures. Abnormal wound healing, especially the keloids, this is important in advanced surface ablation. Marfan syndrome, systemic infection like HIV, TB. If patient is on drugs like steroid, agotripine, delayed wound healing may be there, or if it's on an antihypertensive, antipsychotic, anti-Parkinsonism medicine, these causes more dry eye and fluctuation of vision may be much more common in these patients. So this advanced surface have shown to be one of the safest procedure. So a lot of things has been done, and various research paper articles published that show that safety profile of advanced surface ablation is probably the highest compared to any corneal refractive surgical procedure. And now it can be used for correcting high myopia. Early we were doing it in the LASIK rejects, where the cornea was thin and the number was not high. We were doing PRK in those cases. But now it has come to the mainstream, and the range of correction is gone up to 10 diopter also. So combining with PRK was, Dr. Wabekar has already told here the treatment aim is not refractive correction. That's to be very, very sure. People try to correct the refractive errors. Try to remove only the aberrations there, because you want to preserve the maximum tissue. Even your cornea is 500 micron, 530 microns, it's best to avoid in this case as much tissue as you can preserve. It's not the specs this is causing problem, but you have to play safe. Optical aberration which can't be corrected with glasses or difficult to do with contact lenses even, I think that should be treated, and that should be the aim of combining it. This is how we do topographic treatment that's transferred to our excimer laser machine, and based on that we just take only the aberration part. what Dr. Vavikar was showing you, see porous, we just take the aberration part. We kept the reflection 0, 0, and then we try to treat it. If required, just we can add 0.25 because machine don't accept 0. You can add 0.25 of that. So this is how topo-guided ablation is done. Or coming to the procedure is probably the simplest by any refractive surgery you are going to do. Just put a local drop, paracaine or anything. You can remove epithelium manual. You can use a brush. You can laser scrape. You can do alcohol assisted. But as of now, laser is preferred even for PTK method if you are using. Laser is preferred because that gives a uniform area. And there's less chances of collateral damage to the tissue. So once the epithelium is removed, PRK is applied, use mitomycin. I'll come to that one, put a bandage contact lens. That's all surgery. You have to just focus it, press it, and surgery is over. You have to use antibiotics, lubricating drops. So the earlier with machines and earlier with PRK, what we were getting stomal scarring, irregular astigmatism, persistent corneal epithelial defects, recurrent epithelial erosion, which may cause significant discomfort, and epitheliopathy. Of course, these have reduced a lot now. We hardly get them. So the question comes, how we can improve the results in advanced surface ablation? It's not the machine only. You have to look for some factors. The thing here is, it's recovering by epithelial remodeling. So the recovery is by epithelium. Unlike LASIK where you cover it with a flap, there's hardly any healing. You can leave the flap after 20 years. But here the new epithelium is growing, so you have to control that part and provide the best environment there. So as required preoperative, you have to do careful preoperative checkup. Look for blepharitis, good lid hygiene should be there. If required, you can scrub, use antibiotics. If there's a dry eye, treat it first, maybe with artificial tear. If required, cyclosporin, ointment or puncture plugs even then. Dry eye is common in middle-aged patients. We have to be very, very careful. With the increasing screen time, we are getting more and more patients. So you have to be very, very careful with these patients. From the operative view, we are using one modulator, which is a game changer. That is the mitomycin C, 0.02%. It prevents haze. Then chill BSS that causes numbing of the nerves. Then we use proper fitting contact lens. Whatever the bandage contact lens you're using, you should use a good quality bandage contact lens. Look on the second day. If you're seeing any debris under the contact lens, just change the lens. It's not there, you have to keep it there 5 days. Then contact lens soaked with Acuvol or Accusat for reduction of pain. It's and Narayan Nitrala has promoted it. I think it's to be very cautious, but one can use it. Then newer contact lenses are in the market. They are not available yet, but they are biodegradable. You put the lens dissolve itself in 5 days. So you don't have to require to take it out. So it's from Nexus Vision Shield. I think they'll be soon available to India also. Then NSAID should be avoided. If required, you could use 4 to 5 days, but I recommend not to use it. Of course, many of us are using Acuvol, but we be very cautious in using these things. Then coming to the mitomycin, it's a potent antimicrobial, which inhibits DNA, cellular RNA, and protein synthesis. It blocks keratocystose activation and proliferation, myofibroblast differentiation, and subepithelial collagen formation. It results in preventing anterior stromal scarring. So this is one of the drugs which changed the game at all. In the post-op period, you have to avoid overuse of topical anesthetic. I normally don't use, but I see many persons are using. They are giving paracaine to the patient. It should not be done. Oral steroid I use for a day or two. Now we have got a better oral pain agents. One has to be sure there is a pain, which is maximum in advanced surface ablation. Of course, we have now got a better agents. We can just control them. Avoid aminoglycosides. They are dangerous to cornea. Then improve epithelial regeneration. If you see there is an epithelial defect, give doxycycline for persistent defect. Avoid UV exposure. That's one of the most important things. If you are using UV blocker glasses to your patient, make sure they get a 100% UV blocker, or you provide it yourself. Because if they are going to buy from market, they can buy any glass. It may not be. It may be zero UV blocker also. Nutrition supplements are again good because we want to improve the epithelial regeneration. There should be nutrition supplement like omega-3 fatty acid, vitamin C and vitamin D3 also. So coming to the new technology which has come now, which make the things to come back. It's a smart, Shund has introduced smart surface technology. The surface is very, very smooth, unlike irregular surface. With Elcon, it has come again, Trans-PRK. There's a one step, no touch, no blades, all laser technique. So how is different from steam, like different from routine PTK which we were using earlier? PTK used to introduce some myopia, around 0.75, PTK followed by any treatment profile, it's a two-step procedure. But in this, the procedure PTK is neutral. We are not introducing any aberration, we are not introducing any power there. Because we are putting more energy on the peripheral side, so it's a sort of wavefront optimized removal of the epithelium. Unlike PTK, which treats as like a flat surface, and the removal of epithelium is same micron, it doesn't take the into theory that the mid-periphery cornea is more thicker, as far as epithelium is also concerned. So coming to the range of this advanced surface ablation, it is as good as any LASIK procedure or even the SMILE procedure. Earlier we were limiting it to 4 to 5 microns. Now it has come to up to 10 microns, you can correct it. Of course, if my patient is more than 8 diopters, I prefer ICL in those cases. But there are cases where you can't do ICL. You have to do it in higher myopia. We are also treating this one. And some of the patients are not willing for ICL also. So you can treat hyperopia also. You can, only thing you have to take care, machine allows you up to 10 diopter. That is a total spherical equivalent. In LV Prasad, they are treating up to 13 or 14 diopter also. So it's a one-step trans-epi-PRK, uses same planning sequence as we use in custom Q or wavefront optimize. It's a one-step. There's a no time lag. You feed the data and press the foot switch, and everything is taken care of. You don't have to do the two treatment procedure. First, epithelium is removed, followed by the refraction correction done. Optical zone selection is with correspond to the refractive correction. That's again very important because we're removing minimum epithelial. And the peripheral epithelium, which is very healthy, which is not touched, if you're using alcohol or even mechanical, some debris, some tag may be there, and it may cause damage to the peripheral or even limbus also. But here you are just limiting to the area where you want to do it. And there's a less myopic shift compared to standard PTK mode. There is a uniform removal, more predictable refractive outcomes. Epi-ablation zone automatically determined by the laser based on the PRK ablation profile. There is active eye tracking throughout the entire process. So if we talk of advantage of trans-epithelial PRK as such, there is an accelerated healing and visual recovery by limiting minimum epithelial removal. There is less pain. There is reduced risk of haze by accelerating the healing, by smooth surface and better contour, by removing damaged cells and reducing thermal effect. So the shortcomings, the flip side of that, it accentuates the importance of epithelial mapping for proper surgical planning. If you can have epithelial mapping, that avoids the surprises. I think it's a better choice. It causes more heat because you are combining the two procedures. It's still not available with premium profile, custom Q or Contura. But now people are combining the two procedures. They are doing steam light for removal of minimum tissue. Then you can use Contura or Wavelight Plus, whatever you want to do. And it has a price tag. The companies are very smart. They put a price tag on it for you have to pay click fee. So just to sum up, it's a very gentle, no touch, no cut, no incision, no suction, no cap. It's a very safe biomechanical preservation and corneal stability. It's a stress-free. You don't have to plan so many things and take care of so many things. It's a faster treatment in a single step. The learning is very, very easy. Anybody can learn in just one day. No suction, so you are not putting any suction on the cornea, so it's very safe for the posterior segment if there is a pathology there. Excellent clinical outcomes. Reduced dry eye by leaving the nurse that produces tears intact. Can be combined with CXL. It's economical. You don't require a femto or even a microcotome with that one. So just to conclude why it has come back, there are 3 points which make it come back. Better examer profile now we have finer flying spots compared to what we were having earlier. Broad beam was the PRK game. Then mycin C is the game changer. Third is the better epithelial removal. that is a wavefront optimized removal of the epithelium. These three things had changed the scenario, and now advanced surface ablation is taking over most of the procedures. So surface ablation is one of the most effective tools in the surgical armamentarium of refractive surgeon. It is still underutilized, but it's very promising and exciting with superior results. Thank you very much.
Thank you very much. Very good lecture. Sir, two questions.
Yeah, please.
Number one is that have you tried chilled contact lens?
Chilled contact lens, yeah, that's a very good suggestion. If you are using a chilled BSS, you can use chilled contact lenses. These are very good. They cause a numbing of the nerves and patient don't feel the pain also. So I think that's a very good suggestion. I missed that one.
And second thing is that, sir, do you look at the base curve of the bandage contact lens? Because it is said that one of the pain factors is, tightly fitting bandage contact lens.
I haven't tried it. Only thing, we just see the patient second or third day. If you find any debris inside, that shows the contact lens is not properly fitting, or if it's moving too much, then we just change it. But I've not titrated what you're telling me.
Because once when you look at the patient, people who do have pain, the contact lens is very tightly fitting, whereas people who don't
Yes.
get pain, it's like slightly mobile.
Yes, gentle
Even I
movement
have
is
not tried, but I have been contemplating.
I think that's a very good point.
Did you use the contact lens soap in the anesthetic?
I've tried it earlier. We were getting AccuVeil. It's not available anymore. Even I try AccuSet, but I don't think much of difference. And it's little risky also. So because you're using a keratolec, that can cause danger also, damage to cornea also. So one has to be very cautious. There's no harm in using, but practically I haven't seen much of benefit for this.
And now,
Is there any difference in the result streamline and if you use the TPK and plus WL?
But there's a lot of difference.
yes.
That's the whole, what I told about you. Earlier the PRK, where we're using a laser to remove the epithelium, then PTK mode, then we were doing the laser. That's a two procedure. And if you're doing a single procedure, lot of difference there. First thing, it's a combined procedure. Second, you're removing epithelium in a different way. In PTK, you remove, laser treats as a flat surface and takes the epithelium 40 microns here, 40 microns here, 40 microns here. But in wavefront optimized, is taking 40 microns here, is taking 65 microns here, 65 microns here. So you get a uniform surface. It's taking care of your curved surface. Where the difference? That makes the thing much better.
You don't use doxycycline in every case.
Pardon?
You don't use doxycycline in every case.
No, not at all. If we see there's an epithelial defect there, only then we use doxycycline. We don't. It's not required in routine cases. And it depends. If your ablation is around 40 micron or more than that, it's required. You can use it. Some people are using 20 micron ablation also, but normally for 40 microns you can play safe. And if you want to use it, it's not going to cause any harm. People are used it even for more than 1 minute. We are keeping it just to 60 second upper limit. We don't use more than that. Even the ablation is 10 diopter or something. We don't use it more than 60 seconds, but people are doing it, and it's very, very safe. Only thing, you have to be very cautious once you are preparing it. It should be proper dilution. You have to mix the oil in 10 ml. Either use a 10 ml syringe or that cell and take a part of that. So you have to be very cautious. Sometimes the mixing error can occur for the beginners.
20 seconds we're using in every case. Somehow it's working very well. Even
No, it will work. It's very, very safe. Whether it's giving benefit or not, it's not sure. It's very safe. Once you're using for 60 seconds, it's safe. It should be safe for 20 seconds also. You can use in every case, it's no harm. But I don't think it's low ablation provides any advantage.
Thank you.
Thank you very much.
Very nice.
And
So our last speaker for the section goes Dr. Anand Parthasarthi. He is going to talk on smile all the way.
but not the least, last but
Yeah, not, sorry.
Maximum you've treated with ASA,
I treated around 12 after.
well, and
Then we have to do two procedure basically. We have to combine the two procedure because the machine allows up to 10 diopter. Alcohol machine that allows up to 10 diopter. So you can maximum do 10 diopter in that machine, but one of the patients we did in 12 diopter, he's doing very well. In LVP, they are doing around 13 to 14 diopter routinely.
Okay.
So I would say FDA approves up to 10
That means
diopter.
you're ablating at least 130, 140 microns.
Yeah, because you have to reduce the zone.
Plus the epithelium, right?
Yeah.
So it's
Basically,
almost
the
200.
safe limit is as good as any LASIK procedure. In fact, it's much more because you're leaving much more tissue. Normally, say 300 microns is the safe limit for LASIK. So, in my opinion, that should be the safe limit for advanced surface ablation also.
Okay. All right. Thank you, Dr. Vinod, for allowing me to be a part of the session. And I will be talking about lenticular extraction versus the standard LASIK. No financial interest, but it would be nice to have some. So basically, now a lot has already been done, so I won't touch upon this, but broadly, it's a smaller incision, lenticular extraction, and then the shape is is not permanently altered, unlike flap. Now, there are, of course, some procedural differences. LASIK has already been covered by a lot, but here you have a 2 to 4 millimeter incision, no flap creation, minimal nerve disruption, and preserves biomechanical stability. It is suitable for thin corneas and dry eyes. And this is said to be a more significant procedural advantage. When you look at all the 18 comparative studies in terms of the 6-month surgical results, 95% of the patients achieve 6 or better, compared to about 93 for LASIK. In the long-term follow-up, in terms of stability, at 24 months, the regression was hardly 0.01 diopter for SMILE compared to maybe about 0.08 for LASIK. And this is over 24 months. And this is something that for regression you do occasionally see even if the surgery is done perfectly. In terms of astigmatic correction, which was something the lenticular extraction procedures could not do, both are now actually almost equal. Mean difference is, and even the undercorrection is very, very less. So it is actually matched the LASIK, which was a gold standard for so many years. Corneal nerve preservation is almost 60 to 70% of the cornea versus 10 to 15%. So the destruction of corneal nerve, especially the main trunks, is significantly more with LASIK. The corneal sensation recovers faster, and patient comfort and tear production is actually quite good. When you look at the 222 meta-analysis of 12 comparative studies, the preservation of corneal nerves in lenticular extraction correlates with reduced dry eye occurrence, making it valuable for patients with pre-existing dry eye, especially if you're doing it in patients who already have significant dry eye, like IT professionals. Now, there are some objective dry eye measurements. I won't touch upon it, but tear breakup type, Schirmer's and corneal staining, SMILE is significantly better. There are some visual quality outcomes which are important: contrast sensitivity, night vision quality, and higher order aberrations. And all these, the lenticular extraction actually perform sometimes 12 to 23% much better. So all these translate to a better functional results, including challenging conditions like night driving and low contrast environments. The biomechanical stability, which is corneal hysteresis, tensile strength, and residual bend, and these are all simulations. We do know probably the best is SMILE, comparable to PRK, and LASIK is the least. Now, the complication comparison is something that you would probably need to know. You have microstriae, interface debris, epithelial ingrowth, risk with anything that includes a flap. Minor complications like flap displacements, edge irregularity, dry eye. Major like flap amputation, buttonholes, and infectious keratitis. Thankfully, very less with the femtosecond, but still there. And you can have post-LASIK ectasia, free cap, and severe striae. Just a point to note that any cornea which is not suitable for LASIK will not be suitable for SMILE. Now, just to touch about the surgical technique, remember this, it is very, very sensitive to us epithelial. It needs to be very, very wet. So if you have black spots like this, redock and then do it. This is what you really want as a perfect laser pattern, where you have two levels of dissection. And docking, adopt a soft dock approach, activate at about 70% of the applanation, check for pupil centration. If the pupil is not centered, the centration needs to be readjusted. So you can stop the suction, go up again, and then redock. Check the pupillary centration. Remember that sometimes you may not get pupillary centration, but that is okay because in a lot of patients the pupil is slightly eccentric. So this is how it looks. So you're doing a soft dock, you get the applanation, and at 70% you activate, and once you activate, your pupil will dilate a bit, and the procedure is actually very good. 7 to 8 seconds, you're actually done with the procedure, both anterior and the posterior cuts. The lenticular dissection technique, remember that there are two planes, so you need to be aware of that, and the space is about 0.5 millimeters. So you need to first do the anterior pocket before you proceed to the posterior pocket. And this is important because if you go posterior first, you will definitely have problems. So you open the interface, the incision, and you will see that there's a change in the air bubble pattern. This is anterior is open. Once you have opened, only then you go to the periphery and open the posterior. This is important, and make a small opening so that you don't completely dissect it. Now we are doing the posterior at the periphery so that when you go back and do the dissection, you got to dig in bit and then go up because you got two separate planes. After that, you complete the superior dissection, you need to switch the instrument, which will be a longer instrument which goes over the cornea. So you change there are two different types. One is the slightly sharper dissector, one is the blunt dissector, and you ask or bend or push the eye slightly down and then complete the dissection, and you got to go all the way beyond the margin. So this is an important part because you do not want any part of the anterior part undissected. So the anterior cap has to go till the level of the laser dissection. I'm going all the way till the edges. Now the inferior dissection, this you got to cross the anterior. Remember the posterior dissected more. So you go through the area that you already dissected, and then be a lot more gentle over the visual axis. So over the pupil, I tend to go slightly slower to make sure the dissection is actually complete. And then go to the periphery, leave some part of the inferior part undissected so that it doesn't fold over. Once the central part is complete, you keep the edges dissected completely. So you go at one, you enter the periphery. Remember, one part is undissected. You don't want the lenticule to fold over. So you go both sides, and then the dissection is actually complete. Edge dissection is important because this central island is kept so that the dissection and removal is a lot more better. So I've left that island, and then you go this side. So you got a central part which is anchoring the lenticule. Now you've done most of the work. The lenticular extraction is the easy part. And now you got a complete dissection. You use the special forceps. You can ask the patient to look down. A bit of saline is a good idea. Now the lenticule is out. So even though I've slowed it down to different steps, the whole procedure can be completed in maybe 2 to 3 minutes. There are some complications. Suction loss, black spots, wrong lamellar dissection, folded over lenticule, torn lenticule, and retained lenticule. You can have inappropriate cone size, surface being too wet, poor cooperation, and improper docking. So suction loss can occur anytime during the whole procedure. So the advantage is that you can redock any number of times, but if the conjunctiva gets very, very fluffy, it does become a challenge. So even though the duration of the suction, so if you see these bubbles at the periphery, you know that there is suction loss. So you need to be aware of that. So you will have to go back, dry the conjunctiva, make sure the cornea is wet, but the conjunctiva has to be dry. This I will skip. Sometimes you can have suction loss during laser application. You can actually come back and do it if that is a problem. So you can wait for a couple of hours, the bubble can go off, and you can come back and actually redo this. So this is important. Even though the duration is only about 8 to 10 seconds of suction, the patient needs to cooperate with you, and the blinking green light is a good indication of asking the patient and where to focus. So if you have suction loss during the procedure, you undock, you can wait for 2 hours and get it done. treatment can be done at a later date. So basically black spots indicate surface is too dry or suboptimal energy setting. I won't touch upon this. This is quite common, especially long lamellar dissection, especially important when you're starting out procedure. Usually about 10 procedures you will be able to actually do this. So this is important now to start. So the recognition of the flap, the edge of the inferior, now this is, we have gone posterior directly. So sometimes in very thick dissections, you can go posterior, then it becomes a lot more difficult. You'll have to go to the periphery and re-dissect, but you have to be aware that this is a complication that can occur. I will skip this. So smile-specific complication is difficult lenticular extraction, about 1.9%, tears in about 0.05%, and comes down as the person becomes very much better. So in terms of patient satisfaction, very similar to LASIK, but may take slightly longer initially, especially if your dissection is not very good. Ectasia risk is slightly lesser with the smile, and probably contact sports, water sports, extreme environments, this would be the preferred procedure. Future directions will be faster laser, topography guided smile, hyperopic smile, and automated extraction. I finished. Thank you so much.
Thank you so much, Dr. Anand Bharatwati. Any question to Dr. Anand Bharatwati? So, the newer things are coming in the smile. I smile 500 to is going to 800. What the changes has come in the newer generation of machines?
It's much faster. That is one. Pupil centration, extremely important. And I feel if there is one thing that has really changed is the astigmatic correction in pupil centration. If you are used to playing Xbox or any of those video games, it actually makes it easier, because it's almost like playing a video game. You got to center perfectly, which was not there with the earlier 500. The 800, and I think even the one that Sir has on the Schwind has that centration technology. So that becomes critical.
So I think the smile is again improving in a lot way. You are getting more capabilities now, including the custom treatment, even the hyperopia treatment that's in the pipeline. And soon we will have got more better machines. So at the end of this session, I think we have on the crossroad, which machine is better, which one is better, you can't say. SPK is doing very well. Femtolesic is doing very well. With the topo guided or Waveflight Plus, they are doing very well. Even the advanced surface ablation is now very well. Smile is again giving a good results. So the war is still on. That's why they kept the topic at the war of flaps. The war will be there. I think there's no winner as yet. So you can keep everything in your armamentarium, and depending on the need of patient, that I said in the beginning, one shoe doesn't fit everyone. So you have to have different things. One smile may be good for one, advanced surface and ablation may be good for other. So still we have to have a lot of things in the surgical armamentarium, and depending on the need of patient, we can just tailor the treatment. Thank you very much. And can we have